Today, let's understand rectocele repair and try to learn a few tips and tricks of it. What we are going to discuss today is definition, indications of surgical repair, approach, what has changed over the years in rectocele repair. We'll talk about site-specific repair, and at the end will be a small video demonstration to describe those 10 tips and tricks which we have compiled for you. Unfortunately, most of the available published literature in rectocele comes either from the surgeons or colorectal surgeons rather than the vaginal surgeons, creating confusion in the mind of gynecologists who are in the beginning of their career. So today we'll see rectocele from a gynecologist or a urogynecologist's point of view. Definition-wise, as described by ICS and IUGA, rectocele is a bulge in the posterior vaginal wall associated with herniation of anterior wall of the rectum. If I ask you what are the indications of surgical repair of a rectocele, the answer is simple. It should be symptomatic. Other causes of defecation disorders are ruled out and conservative managements have failed. But one of the most difficult and debated questions in the surgical practice is whether to repair or not an asymptomatic rectocele during POP repair surgery. So suppose if patient was symptomatic for cystocele and there was uterine prolapse and patient complained of bulge and other symptoms, you repaired it. But in the end, if you find a rectocele and patient is asymptomatic, the question is whether you should leave it alone or you should repair it. As per our experience, this rectocele, when you are doing a reconstructive surgery, should not be left behind. It should be repaired. Why? Because once you have repaired all the compartmental defect, the rectocele, which was still pushed inside because of the other compartment defect during prolapse, will now become symptomatic when you have repaired other defects. Based on the route of surgery, there can be various approaches to correct rectocele, like transvaginal, transanal, transperineal, and even transabdominal. To date, there are no control studies comparing these different techniques of repair. So what we are going to do, we will do what we do best, that is the vaginal route, or what we call as transvaginal or transperineal route. Now, when we talk of a transvaginal or a transperineal route, which is the choice for a gynecologist, there can be traditional colpoperineography or a much talked about site-specific repair. But we must understand one thing, that when we are repairing a defect, the goal is to relieve symptoms, yes. Restore anatomy, yes. But it is also our goal or duty to restore or maintain her sexual functions. In this regard, there has been a change over past few decades regarding the traditional way how we have seen rectocele being repaired versus how we do it today. And this significant one change which we have adopted in our practice comes from lot of evidence. And what I'm talking about is levatorplasty. So in various studies, it was realized that levatorplasty or levatorplasty improves functional outcome, but it hampers the sexual functions, thus should be avoided in young women who are sexually active. The next question is, if we leave behind the sexual symptoms or dyspareunia, we can say it de novo dyspareunia, which occurs after levatorplasty, does levatorplasty help in improving defecatory symptoms? The answer to that also is no. Combination of levatorplasty during rectocele repair had limitations in improving defecatory symptoms in these patients. Now, this one is an interesting study, rather a meta-analysis of around 9 studies in a long period of time from January 1991 to December 2020. For over 3 decades, this study included all the studies which were done. And finally, it included n number of patients which had omission of levatorplasty. That means levatorplasty was not done in those women, in 71 of these women. But what was interesting to see that the post-operative improvement of defecatory symptoms was similar to that group, or even better to that group of patients who actually had undergone levatorplasty. And I'm sure if you are the one who had done many rectocele repairs and done levatorplasty as a concomitant procedure during that time, you would have realized that some old women who were not having defecatory symptoms before, in the post-operative period, they start having de novo complaint of difficulty of evacuation as well as constipation. With this background, in today's clinical practice, it is not recommended to do a concomitant levatorplasty until and unless it is specifically indicated for women who undergo a rectocele repair. So traditional colpoperenniorrhaphy, when we do now, we do not include levatorplasty or levator ani muscle plication as an integral part of the surgery. Rather, it is selected from case-to-case basis. So in traditional colpoperenniorrhaphy, you know what we do. We remove a vaginal flap, which is the redundant vagina, bring all the Denonvilliers fascia in the midline and plicate it. And over that, cover it with the remaining vaginal skin which has left behind after removing the redundant vagina. This is in short how we do traditional colpoperenniorrhaphy. But from this traditional colpoperenniorrhaphy, we have moved one step further now, and we talk more about site-specific repair. So what is the site-specific or defect-specific repair? Site-specific or defect-specific repair means that you identify where the defects are in the Denonvilliers fascia and then repair them accordingly. If it is a transverse defect, repair it in that direction. If it is a vertical defect, repair it vertically. To understand the entire site-specific repair, I am going to quickly demonstrate you the important steps, how it is done in today's surgical practice. First step is that the diagnosis of rectocele should be confirmed. Though perineocele, rectocele and enterocele all are the defects of posterior vaginal wall, however, the surgical management of all three are different from each other. Tip number 2 is infiltration. We infiltrate the tissues at an angle of 0 to 15 degrees with cold diluted adrenaline solution. Rather than a midline vertical incision or a T-shaped incision, what we prefer to use now is an inverted V or a diamond-shaped incision, owing to the fact that in the midline, usually the vaginal epithelium is at its thinnest. So it is better to start laterally and then come medially. For rectocele, both sharp and blunt dissection are required. Sharp dissection for the standing fibers and blunt dissection with the help of a gauze piece is done for the endopelvic loose tissue. Tip number 5 is hemostasis. Rectocele dissection bleeds much more than a cystocele dissection. So to keep your field clean, have a very good hemostasis, which can be achieved with Trenexa administered by the anesthesiologist or by cautery or even by ligating the vessels if it is required. Once the redundant portion of the vagina is completely dissected off the underlying tissue, it is cut and removed. Once you have done this, the next important tip is to create a clear margin of 1 to 1.5 centimeters all around. And why is this done? To avoid any impingement of tissue when you are taking and tying the sutures towards the end of the surgery. Now you can identify the defects properly, and here two fingers which are kept in the rectum help to delineate these specific defects. Can you see them clearly? These are the defects in the Denenvilliers fascia. Now with one finger supporting the rectal wall from the rectal side, the other hand uses sutures through the tissues to repair these defects. Now, important thing here to understand is as you are taking these interrupted sutures, don't start tying them. Keep them tagged with the help of an artery forceps to be tied at the end. This will prevent missing of any defect which might happen once you tie the suture. The visibility might be limited. So take individual sutures one by one, but tie them at the end. And last is when traditional teaching merges with the new theories and new concepts. In here, we say that even if you have repaired the site-specific defects in the Denenvilliers fascia, again, judge the need for a midline plication because there can be some injury-related defects, but it is very much possible that the patient has a global attenuation of the endopelvic connective tissue. Both pathologies can exist together in one single patient. So if you feel that after defect repair, if the bulge has not completely gone inside, check the thickness of the Denenvilliers fascia once again, and if required, do a midline plication too. And here you can see, as we are doing a midline plication, it is serving two purposes. The bulge is reducing and also the lateral defects, which were little bit difficult and out of sight when the bulge was still there before midline plication, become much clearly visible and easy to repair now. And with this, the surgery is almost complete. You just have to close the first incision in a vertical fashion, which you have initially given in the form of a triangle or a diamond shape. You can feel the new formed thick Denenvilliers fascia now, and then close the vaginal incision. Let me quickly summarize the 10 tips I told you to remember during a rectocele repair. First, confirm the diagnosis. Rectocele, enterocele, and perineocele all are the defects in the posterior vaginal wall. The surgeries of all these three are entirely different from each other, so confirmation of diagnosis of rectocele is very important before you start repairing it. Infiltration, as I always keep on saying, plays an integral part. The angle of infiltration should be 0 to 15 degree. Incision, rather than a midline incision, go for an incision where you can start dissecting from the lateral end because the middle portion of the rectocele is usually the thinnest one. Dissection, we need both sharp as well as blunt dissection. You must decide where the standing fibers are and go for sharp dissection there. Hemostasis plays extremely important part in any surgery and also in rectocele surgery. Do anything, whatever it takes to keep your planes clean, your surgical area clean, so that you can proceed without a blurred field and minimize complications. Clearing the margins to prevent impingement of tissue again is a very important point. Now, defect repair needs identification of defect, which is done with a finger or two in the anal canal or rectum. During the repair also, if you keep your fingers there and support the tissue from behind what you need to repair, it will prevent some complications like needle piercing through the rectal wall, or in high rectocele cases, even through pouch of Douglas or maybe small intestine. Sutures need to be taken but tied at the end, one by one. And don't forget, you don't do just site specific repair. Many women may have a global attenuation of endopelvic connective tissue. If it is there, don't forget to do a midline plication also in these cases. And that's it. Hope it helped.